So good afternoon, everyone. My project is about the advances in endoscopic ultrasound-guided biliary drainage. My name is Panagiotis Paraskevopoulos. I don't see it here. No, I see. And I have two projects. One is the combination of hepaticogastrostomy and antegrade stenting for malignant biliary obstruction is justified. And the other one is about some devices and outcomes in hepaticogastrostomy. So for my first project, the prevalence of malignant biliary obstruction is approximately 15 to 100 people. And in those cases, usually ERCP is what is done. But there is a subset of patients, such as those with surgically altered anatomy or duodenal obstruction or even papillary tumors, or even, as Edina mentioned, if the cannulation is not proper, it can fail. And in these cases, what we usually do all those years is percutaneous biliary drainage. And in the last decade, the ultrasound-guided biliary drainage has emerged as an alternative option. And compared to percutaneous biliary drainage, it's associated with significantly better clinical success, lower rates of post-procedural adverse events, and fewer interventions. So for this reason, I looked over the literature and I found that there are studies that compare hepaticogastrostomy with hepaticogastrostomy with antegrade stenting. In the one case, it's basically a connection between the stomach and the liver, the B2 or B3 bile duct. And in the other one, it's just a normal ARCP, but you just go from the liver. So you can imagine antegrade stenting as a normal ERCP stent. So for this reason, we compared the two. We have both direct and indirect comparisons. And as you can see here, both the antegrade stenting and hepaticogastrostomy can be used to actually, basically in the same cases, so somebody combined them. So we searched in 4 databases, and we ended up with 25 articles. And for this reason, now I'm going to show you the direct comparisons. For the direct comparisons, we have 5 articles. In the upper left, you can see the technical success. And as you can imagine, for the technical success, 2 stents are harder to place than 1. So this is what we see in our results. Of course, because of the low number of studies, one of the cases happened that the hepaticogastrostomy and antegrade group was 100%, and this skewed a bit the results. But still, you can imagine normally that this would be the case, that it would be harder. The other important and maybe useful one to mention is the bottom right, which is the reintervention. Here we found only 3 studies and actually pretty significant results, if we can say that 1 in 2 or 1 in 3 patients don't require as much reintervention, which is pretty good and significant. So we also performed the indirect analysis with pooled results. We can see here that, of course, the rate of success in hepaticogastrostomy is higher than hepaticogastrostomy with the antegrade stent, because, again, it's 2 stents and not 1. For the clinical success, the different studies had many definitions. Basically, what we regard is like a reduction in bilirubin around 50% within a month. This is like the inclusion definition that we used. And in this case, we found actually significant results again. And we found that in the case of hepaticogastrostomy with antegrade stenting, the clinical success is more often encountered. Lastly, for the overall adverse events, we can see that there is not much difference. Actually, what is interesting here is that in reality, bile leakage, which is a very important problem with hepaticogastrostomy, is reduced. But because with the addition of the antegrade stenting, you can also have pancreatitis, in the end, the overall adverse events will remain similar. So yeah, this is not very good, but what it shows, basically, I can tell you, is that we had only 1 case of bile leakage in 200 patients in the hepaticogastrostomy with antegrade stenting, and in the other case, we had 27 in 400 patients, which is pretty significant, and this is actually pretty good. So when I first started here, the thing that I wanted is to find a project that had the most probability of being published in a good journal, and I searched a lot. I found this one. I thought it was okay. Unfortunately, for the first submission, it did not work out, so we're planning to submit in the second one in endoscopy. And for my second project, which I have not started yet completely, I'll just say a few words that one of the problems with hepaticogastrostomy is that there is a high risk of stent migration and bile leakage. As I mentioned before, the addition of the antegrade stent will reduce the bile leakage. And for this reason, because if you can imagine, the stomach is a movable organ, so the stent can basically move. There are some novel devices such as anchoring hooks that basically can minimize the risk associated with the procedure. So for a clinical question, we're basically going to see patients undergoing hepaticogastrostomy, and I have not looked over all the data to have like a final saying on what is going to be on, but for sure we have data for plastic and metallic stents, for clinical success, technical success, adverse events, and definitely time to stent dysfunction, which for metallic stents, as you can imagine, is usually higher than the plastic ones. So we will soon do the Prospero registration and start with other projects. So in summary, although my project is a lot about hepaticogastrostomy, I would not recommend these procedures, except for a specific subset of patients. The thing is that they are complicated, and there is a better alternative, which is called a duodenostomy. So if somebody would like to actually perform these procedures, I think this one is more easy and better, with better results. Thank you for your attention.
So congratulations. I just have one question which remained after your speech. Why, if you do not recommend this procedure, why you don't focus on the second one that you said, like holoduodenostomy, for your second project, maybe?
Yeah, that's a good question. For two reasons. One, because if you have novel devices such as the anchoring hooks, you can increase the better outcomes, so it's worth checking. And secondly, the holoduodenostomy and hepaticogastrostomy have been compared a lot, so there's not much room to check things.
Thank you.
The indication is sometimes definitive. Then if you have a higher biliary obstruction, higher malignant biliary obstruction, then the holoduodenostomy will not resolve anything. So in that case, no choice, you should do hepaticogastrostomy. Yeah, that's the point, what we should speak about it.
Yeah, it really depends on the location of the tumor also, because this is where the stent is going to also...
In distal, there is no point, and the distal holoduodenostomy is there. Yeah.